Welcome, everyone. Let's begin by establishing a clear clinical definition of systemic lupus erythematosus, or SLE. At its core, SLE is a chronic, multi-system autoimmune disease. When we describe it as chronic, we are highlighting its persistent long-term nature. However, it is the multi-system aspect that truly defines the disease's complexity, as it can affect virtually any organ in the body. The underlying mechanism here is a loss of self-tolerance. This leads to the hallmark of SLE, the production of autoantibodies. These are antibodies that mistakenly target the body's own self-antigens, the very proteins and nuclear components that should be protected. This immune failure triggers a cascade of widespread inflammatory damage across various tissues. Essentially, the body's defense system becomes the primary driver of injury, leading to the diverse clinical manifestations we see in practice. Understanding this foundational inflammatory process is crucial before we move forward. Moving into the etiology and pathophysiology of SLE, it is essential to view this as a multifactorial, perfect storm. Genetically, we see strong associations with HLA-DR2, HLA-DR3, and C1q deficiency. These predispositions are often ignited by environmental triggers, specifically UV light and viral infections like EBV, and are significantly influenced by estrogen, explaining the high prevalence in women of childbearing age. At its core, the pathophysiology involves a fundamental loss of immune tolerance, leading to B-cell hyperactivity and the production of nuclear autoantibodies. This is driven by the defective clearance of apoptotic debris, which provides a persistent source of nuclear antigens. Tissue damage then manifests through two primary pathways. Type 3 hypersensitivity, where immune complexes deposit in the kidneys, joints, and vessels, and type 2 hypersensitivity, involving the direct antibody-mediated destruction of blood cells. This complex interplay explains the systemic nature of the disease. Now, let's focus on the clinical presentation of SLE, a multi-system disease with diverse manifestations. Dermatologically, the hallmark is the malar butterfly rash, which is clinically distinctive because it spares the nasolabial folds. We also see discoid lupus, characterized by raised scaling patches, alongside photosensitivity and non-scarring alopecia. During your physical exam, be sure to check for painless oral or nasopharyngeal ulcerations. Moving to systemic involvement, patients frequently present with non-erosive arthritis, typically affecting the small joints of the hands. Serositis is another key feature, manifesting as pleurisy or pericarditis. Crucially, look for signs of lupus nephritis via proteinuria or cellular casts, and neurological symptoms ranging from seizures and psychosis to transverse myelitis. Finally, hematological cytopenias, including leukopenia, lymphopenia, thrombocytopenia, or hemolytic anemia, are common. Recognizing this specific constellation of clinical features is the first step toward an accurate diagnosis. Let's turn our attention to the 2019 Euler/ACR classification criteria, which represent our modern gold standard for identifying SLE. To meet these criteria, a patient must achieve a total score of 10 or more. Crucially, there is a mandatory entry criterion: an ANA titer of at least 1 to 80 on HEP2 cells. If this isn't met, the patient cannot be classified as having SLE under this system. Once this threshold is crossed, we accumulate points across several domains. Clinically, we look for constitutional symptoms like fever, hematologic markers such as leukopenia, and joint involvement like arthritis. We also monitor for renal impact, specifically proteinuria, exceeding 0.5 grams over 24 hours. Immunologically, we assess for complement consumption through low C3 or C4 levels and highly specific serological markers. The presence of anti-dsDNA or anti-Smith antibodies. This weighted approach ensures a highly specific and sensitive diagnosis based on these parameters. Moving to investigations, our initial screening relies heavily on the ANA. With a sensitivity exceeding 95%, a negative result makes SLE highly unlikely. In your baseline bloods, look for lymphopenia on the FBC and an elevated ESR, which typically mirrors disease activity. Crucially, the CRP is often normal in SLE. A significantly raised CRP should instead alert you to a concurrent infection or serositis. To screen for renal involvement, we use urinalysis and ACR, though a renal biopsy remains the gold standard for classifying lupus nephritis. For diagnostic certainty, we look for our highly specific markers: anti-dsDNA, boasting 99% specificity, and anti-Smith. Supporting tests include complement levels, where low C3 and C4 indicate active disease. We also screen for antiphospholipid antibodies and a positive direct Coombs test. Finally, a chest X-ray is essential to identify pleuropulmonary complications like effusions or pneumonitis. Moving to management, our strategy is strictly tailored to organ involvement. Our primary goal is clinical remission or low disease activity while aggressively minimizing steroid toxicity. For every patient, we begin with non-pharmacological essentials: high SPF sun protection and smoking cessation. Additionally, hydroxychloroquine is recommended for all SLE patients to reduce flares and improve survival. Regarding symptom control, we use non-steroidal anti-inflammatory drugs for mild musculoskeletal issues and corticosteroids for acute flares, always tapering to the lowest effective dose. To achieve this steroid-sparing effect or to manage organ-threatening disease, we utilize immunosuppressants like methotrexate, azathioprine, or mycophenolate mofetil. For refractory cases, belimumab is an option, while rituximab is reserved for severe renal or CNS involvement. In life-threatening emergencies, such as alveolar hemorrhage or rapidly progressive glomerulonephritis, we must escalate immediately to pulsed IV methylprednisolone or cyclophosphamide to preserve organ function and patient survival. Now, let's focus on the high-yield pearls, frequently tested in the MRCP. Regarding diagnostics, ANA is your screening gold standard due to high sensitivity, while anti-dsDNA and anti-Smith offer the highest specificity. A classic laboratory discordance to remember is a raised ESR alongside a normal CRP. If the CRP rises, investigate immediately for infection or serositis. To monitor disease activity during a flare, track rising anti-dsDNA titers and falling C3 or C4 complement levels. For drug-induced lupus, triggered by hydralazine, procainamide, or isoniazid, look for anti-histone antibodies. Note that renal and CNS involvement are rare here. In the kidneys, class 4. Diffuse proliferative is the most common and severe histological subtype. Finally, in pregnancy, SLE increases risks of fetal loss and preeclampsia. Continue hydroxychloroquine, but avoid teratogenic mycophenolate. Also, watch for maternal anti-Ro and anti-LA antibodies, which are associated with neonatal congenital heart block. And that brings us to the end of today's session. I hope this has been a valuable and clear overview. To truly consolidate this knowledge, I encourage you to take the next step. Visit our online platform at mrcpelite.com. There, you can create a free account instantly. You will find a structured slideshow summarizing today's topic, followed by 2 dedicated self-assessment tests. One for MRCP Part 1 and another for MRCP Part 2, each containing 20 focused questions. Take these tests to actively engage with the material. The platform will provide you with an immediate score and, most importantly, detailed, illustrated explanations for every answer, helping you fix the information firmly in your mind. To supercharge your preparation, consider upgrading to a pro user subscription. This unlocks powerful tools, unlimited disease-specific search queries, unlimited access to high-yield exam pearls, unlimited interactive flashcards, and most critically for your exam readiness, full exam board access with 50 question banks for every MRCP subject, and realistic mock exam simulations for both Paper 1 and Paper 2 that closely mirror the actual exam environment. For a limited time, we are running an exclusive offer. Gain all these pro benefits for just $50 for a full year. A significant saving from the standard price of $250. So, head to MRCP-Elite.com now. Start with your free account, test yourself, and explore how the Pro upgrade can transform your revision journey. Thank you for your time and all the very best for your studies.